Good morning, everyone, and thank you for allocating your time in this spring break. It's not a good time for this lecture, but I'm sorry when we planned for the time of these lectures, we were not, informed about spring break is a part of this scheduling for the events. So I'm so sorry and thank you for allocating your time to join this CME lecture. Welcome to the fourth talk on the quality improvement series in a joint CME program by Larkin Community Hospital and Florida Medical Association. I appreciate Larkin and Florida Medical Association for supporting us in planning these credited lectures. I'm Sima Marzban, physician, PhD in health system administration, and MPH in healthcare leadership with years of experience in clinical practice, academic research, quality improvement, and executive responsibilities. In a summary of what happened in the last lectures, we discussed in the first lecture how to find quality gaps in the clinical setting, how to find some topics for quality improvement research projects. We reviewed a list of quality problems together in the first lecture. And in the second lecture, we talked about the strategies to internalize and establish the continuous improvement culture in our clinic, in our clinical workplace, as the contextual enabler for quality improvement projects. In the third lecture, we reviewed aim statement, how to develop aim statement, drivers mapping, and strategies to achieve the aim of the quality improvement project, and how to map a key driver diagram. Key driver diagram is a helpful component of quality improvement planning because in key driver diagram, we clarify our objective goals and how to achieve those objectives. Today, we move forward to the next level, that is planning for a change. So today we discuss how to plan for a quality improvement project. I will introduce different tools and toolkits, strategies, and how to document those data in your project planning. So it would be very helpful for people who want to have a very summarized and brief, straightforward planning for quality improvement project in clinical programs. We will review essential steps and applied tools being used in a quality improvement project designing today. So let's just see what would be our outline today for this lecture. The first step is issue statement. Second one, understanding issue using some tools. The third step, again, understanding issue using another tool. Then how to define and precise areas of focus in our project. Then 3 methodologies. Today we discuss PDSA method. We discuss failure mode and effect analysis, FMEA, and we discuss co-design methodologies. Then after, again, we review and remind what was driver map and what are measurable outcomes. Measurable outcomes would be discussed in the next lecture in detail. Project planning and activity timeline. So those items would be discussed in today's lecture. Let us see what are learning objectives. First, conduct critical thinking. Critical thinking is a competency of medical education, and it's a competency for quality improvement projects and quality improvement teams. Second objective is construct a methodological and time-bound plan. And the third one, informing plan by realistic anticipation of change barriers and how to overcome those challenges. The first approach in quality improvement project, the essential approach is setting the stage for change. How we can do it with a model for improvement. That's one of the approaches for quality improvement planning. Model for improvement. PDSA is a type of model for improvement. PDSA methodology is a type of methodology for improvement. So the first step was, what are we trying to accomplish? How will we know that change is an improvement? It's very important. Why? Because sometimes we think all of the steps that comes to our mind, all of plans and solutions are functional for change. And those solutions are working for our purposes, for our goals. But not always, this is not always the things that we bring to the workplace and we add to the process are functional and beneficial. Sometimes those solutions add the complexity of the work. Sometimes they are not evidence-based. Sometimes they are not proven. They haven't been proven by other researchers so far. So it is better to go to the literature, search the literature, and find what is functional for our system. So this question is important. For example, if a resident is a faculty, or if a quality improvement team bring a test, bring a form, bring a questionnaire, add something to the process, suggest something for patient care, suggest something for patient education or family education or clinical team education, residence education. We should define, we should understand, are these solutions, are these education, are these forms and additional steps, are functional, are value adding, how we can understand this, how we can realize and recognize the value of this additional step through evidence search, searching evidence to find how researchers, how clinicians, how other teams used this solution before, and how was the results of applying these solutions. This is a very important question. Always I ask it from residents who are bringing an idea for quality improvement project, that how do you prove that this solution works? What change can we make that will result in improvement? So precising and defining and describing the solution, the intervention, would be very important to consider in quality improvement projects. So the first step, development and aim statement. Second one, determine how to assess or measure your progress. Measurement would be an integral part, essential part of quality improvement project, and identify the tasks required to achieve. Tasks and activity planning for achieving those aims are important to be defined, are important to be precise. And how is the timeline? Who is responsible for each task? That is the action planning for achieving those aims. Okay, in aim statement, we are replying to these questions. What do you hope to accomplish? For example, increasing cardiac rehabilitation referrals, enrollment and participation for patients with eligible diagnosis. So this is inclusion criteria for people, for audience who are participating in this research and are included in our approach. Pay for patients with eligible diagnosis, MI, CABG, PCI, to improve health and save lives and reduce hospital readmission. This is the importance of that. It should be included in aim statement. And we will do this improvement through automatic referral with effective care coordination. You see how we structure aim statement by including the aims, audience, importance, and how we will do this improvement or quality improvement project. And this is the thing that we discussed together. We aim to increase the number of patients with MI, PCI, and CABG who are referred, enrolled, and participate in cardiac rehabilitation by 30%. So it's something measurable. This is a SMART goal. It's something that has been precise to what extent we want to improve our performance. This is important because, and we will accomplish this aim by implementing automatic referral with care coordination by March 31. So it is time bound. We intend to see 30% increase in current participation rate by December 31. Everything is measurable. Everything is with, figures and something that has the capacity to be measured and followed up. And that would be aim statement, a SMART, measurable aim statement. Let us review what are SMART goals. SMART goals are specific, measurable, achievable, or attainable, relevant, and time-bound. So these goals of the aim should be measurable, time-bound, and achievable, something realistic. Okay. We will include all of those items in project charter. This is an example of quality improvement project charter. You see here, institution is City Hospital Cancer Center. Project title is reducing the proportion of patients receiving chemotherapy in the last 2 weeks of life. And problem statement, always use some facts. Let us review this. Analysis determined that for calendar year 2016, the percentage of patients who had chemotherapy within the last 2 weeks of life was 60%. The comparative benchmark showed that 10% of patients should receive chemotherapy in the last 2 weeks of life over the same reporting period. So you see here that problem statement compare the current situation that is fact-based. So they have some numbers here, current situation, fact-based and data-oriented have been described. And then it is compared to an ideal and expected thing that is a benchmark, facts from literature review. And then for closing this gap, they have defined this aim statement. By October, City Hospital Cancer Center will reduce the percentage of patients receiving chemotherapy. How much? To less than 10%. So that's something SMART for aim statement. It's measurable, attainable, because the facts here, the figures here should be something achievable. If you say 100%, all of the people should receive this, we will improve totally, fully. Those are not attainable. So be realistic in defining your aims. And then a scope of the study, who are included, measurements, overall percentage of the patient receiving chemotherapy within the last 2 weeks of life. You see how these measures are precise and measurable. It doesn't say, for example, effective chemotherapy among people, effective procedure among who are eligible for this. So everything would be subjective when you talk in that way. But here, everything is objective. Percentage stratified by disease area. admission and ICU status. Organizational and alignment and strategy, strategic priority. It would be important to define and select a topic that is aligned with the strategic priorities. For example, strategic priorities of ACGME are practice improvement, improvement of the practice. The other one is patient safety. The other one is incident reporting system. The other one is learning and sharing incidents that are reported and documented in the hospitals. Many of the equity is the other part. Quality of services are the other part. So those are upstream policies that shed light and guide us how to design and define our project perspective and idea or topic, milestones, responsible people, and key dates and events for the project, and then project team members and roles. That was an example. The other example, quality improvement project charter, like this: aim, problem, importance, expected outcomes. You see here, expected outcome is specific objectives and numerical targets, measures, risks, barriers. This component is new in this project charter. Stakeholders who are very important: in a scope, out of a scope, scheduling, and project team member. Another example, these are examples, you know, to internalize and internalize these type of project charters in your mind. When you start a quality improvement project, you need a plan, a written plan. Problem statement again. Here, problem is significant variability exists in the pre-operative, intra-operative, and post-operative management. You see, the problem aims is achieving greater than 30% compliance. The team realized that their compliance now with those guidelines, advanced guidelines, is only, it is 0% they are compliant with the procedure, with advanced systems. And their aim is achieving greater than 30% compliance. So from the situation that they don't have any compliance with an advanced guideline, they are planning for at least 30% compliance. Importance of this compliance: in a scope are surgical oncology clinic, pre-care, operation room, and the other out of scope, all other clinics, procedural areas. How it starts, how it ends. It starts with patient's preoperative surgical oncology clinic visit, and ends when patient is discharged. What are measures? Main measure is compliance, percentage of compliance. And there are other secondary measures like length of hospital stay, or you know, this is average length of a stay. ALOS is an indicator in hospitals. Unanticipated ICU admissions. So you see, measures are very precise here. Scheduling: what are key dates of this project, and what are resources, people who are engaged in this process. Another example, our Larkin project charter. We designed this project charter last year in our department. You see here, project title, contact person, department, team members, initial team members, because we are connecting these people with team 11 volunteers for research. So that was the initial team members. Existing issue: what's existing issue? Poor documentation of pre-operative assessment. You see here that we used minimal words instead of the other examples that they have described the importance and existing issue with facts, the ideal numerical facts, benchmarking, current situation, everything was data oriented. But here we were satisfied with minimal words because it's clear that poor documentation of assessment. And then the plan is knowledge-based risk stratification for pre-operative assessment. The doing phase or implementation phase is questionnaire evaluating. The check phase is something else. And here you see that our quality improvement team will review the data before the submission date and after that. So it is there is no clarified measurement here. What would be measured? The only thing that has been mentioned is how effective. And I told that this type of words are stereotypic, effective, optimized, increased, or developed, something like that. Those are stereotyped words for quality improvement. It's better to turn these words to something like we will increase something measurable by which date, by how percentage, or which numerical purposes or targets. As we talked, it should be fully measurable and trackable, measurable and trackable through defining smart objectives and goals. And in the ACT phase, again, we will design a stepwise risk stratification assessment guideline. Let us review these with these, with these examples that they are measuring something very objective. We don't have any objective, but advantages of this project charter is using a methodology, using a method, a defined method that is PDSA for the quality improvement project, and defining each step by step. We will discuss these steps of PDSA. Okay, so far we reviewed how to state the issue, how to develop aim statement for quality improvement project, and what are project charters. Project charters have been discussed up to now. Now we want to analyze the issue using some tools, like fishbone diagram. Fishbone diagram or cause and effect diagram are tools that we can discuss the issue. We can understand the issue. You see here that solving the old problems of healthcare doesn't require more solution. It requires better understanding of the problems. Through using these tools, we would be able to understand the issue. You should put the issue here in the fish head, and oncology residents who are participating in this study have developed fishbone, used this item, used this tool to illustrate how many variables contribute to a seemingly simple question. Why don't we get paged sooner? So they are seeking for contributing factors to delay, to time waste. So they categorize contributing factors to patient category, patient relevant category, front desk category, providers like clinicians and nurses, culture relevant category, IT category, and method category. So they have discussed this, brainstorm, and then documented everything here. This is a template for fishbone or cause and effect diagram for quality improvement project. Team should be documented here, project title here, and we can put these items in the fish head. See here, inappropriate use of a technique can be mentioned here as a topic. Incorrect documentation, late diagnosis, undone follow-up or missed procedure, overuse of a prescription, misuse of an equipment, lack of expertise, late treatment, incorrect prescription, incorrect dose, overlap the steps, patient refusal, inadhered patient, or pharmacy errors. Everything should be, so those are just suggestions. We discussed a list of these quality gaps and quality errors in the first lecture, and what are potential topics for quality improvement projects. But everything should be, everything that you realize this is a gap, this is a challenge, this is an issue in our department can be mentioned here. Then you can analyze what factors are contributing and resulting in this problem. Okay, we developed aim statement. We analyzed the issue through fishbone or cause and effect analysis tool. This is another tool that I'm introducing to you to analyze the issue. Sometimes issues are not simple to discuss them through some sort of categories like people, environment, and linear causality. Sometimes issues are very complex. They are a result of interactive influence of multiple contributors, multiple factors, multiple issues. For example, inside the hospital, we have a system. Everyone can affect the issue, from IT department, EMR, pharmacy, patient management, receptionists, administrative people, to high-level clinicians, faculty, residents, sub-interns, nursing department, registered nurses, nurse practitioners. Everyone can have an effect. So it's on the inside the hospital, in different touch points of the healthcare delivery, in outpatient clinic, inpatient clinic, bedside of the patient. So you see, inside the hospital, we have many factors, many influencers on the issues. Again, we have many other factors in the clinic of a PCP. We have many other contributing factors at home: patient, family, health literacy, housing, employment, family numbers, family engagement with disease, psychological and socioeconomic status of many factors are working together and affecting each other. And all of those factors affect the process of patient management and healing the pain and healing the chief complaint of the patient. So having this approach help you to understand issues better than linear causality. So I'm hopeful that it takes 1 week lecture to work on systems thinking and these types of tools, but I tried to summarize everything here. You see another rich picture here. Housing, financial resources, positive influencers, community influencers, role models, family obligations, communications, racism, everything affects patient situation. And here we have a part of a study about factors influencing the health behavior of Indigenous Australian from the perspective of people who support Indigenous groups. So here you see that's the result of a study with a rich picture. You can use rich picture instead of fishbone. And you can use many simple, softwares, even Word, to develop this type of illustrations. You can use shapes in the Word platform, but fishbone is something easier. So we can use fishbone instead of this, because having systems thinking needs higher cortical function, higher, higher level, qualified level, a professional level of expertise for people to see everything interconnected, systematic, and in a complex way to see everything that affects the issue. Okay, after using those tools to analyze the issue, again, I review from the beginning. We developed aim statement. We developed our project charter. We analyzed the issue through using different tools. One of them were Fishbone. The other one was Rich Picture. We have many other tools, but those are my, just introductions in this lecture. Now we should focus on areas that improve outcomes for patients. We should focus improved efficiency of staff and less waste due to process failure. We cannot solve all of those factors in our Rich Picture or in the Fishbone. So we should be very precise and applied in our approach for quality improvement. You see here from that Fishbone, I only focus on this area, awareness of the patient about their medical history and medications, and scheduling more patients than staff or room capacity. That is something cultural among front desk people or patient receptionists. So we want only to change something very precise, very objective. So it is better to limit the scope of our intervention. This is the moment that we decide about the scope, in a scope and out of a scope. Other facts, other contributing factors are out of our scope in our project right now. So we should be very precise and very objective to define what are our feasible, attainable parts of this intervention. After that, we should know our stakeholders. Who are stakeholders of this quality improvement project? It is important to know the list of stakeholders. And this is important here. What are we hearing from our stakeholders? We, physicians, we don't used to hear stakeholders' views or opinions, but quality improvement recommends us, suggests us to hear stakeholders' views in a scholarly way. For example, brainstorming, focus group discussions, bring every people who are a part of this a part of this project, and they can affect the outcome of our project around the table and discuss your ideas. What is our data telling us? It's important at the same time that we are hearing stakeholders' views and opinions about that. For example, people who are receiving those care, who are receiving those services, at the same time, what are our data in our EMR or EHR say us? So that's important to combine different sources of the information to define a good quality improvement project and who we need to be on a project team. Let us see who are stakeholders. Stakeholders of a quality improvement project can be a part of hospital, long-term care, community support, home health, palliative care, EMS, physician office. But consider that inside hospital, we are different roles. You can mention those people. Keep this big picture in your mind, but for your project, you should identify who are stakeholders. And this is the tool that you can document the stakeholders. This is a tool for a stakeholder documentation for quality improvement project. For example, here, one of the stakeholders is Health Information Systems Officer. They don't like to do the changes in the EMR. You see, The quality improvement team is insightful about interest of different people that can affect your project and your ideas and your outcomes. Not necessarily interested, but they are designing actions, how to engage these people with the quality improvement project. So here you see a template for a stakeholder analysis. Again, we had aim statement, we had the project charter, we had fishbone analysis as a part of quality improvement project, and then rich picture if you want, and then a stakeholder analysis, who are engaged with the project. These are potential members to be engaged with your project. You see a list of people. You need some names here. You need some names as quality improvement team. Improving critical care team includes these people. It could be 4 or 5 people, but keep in mind that none of residents or fellows or faculty can change a process inside your department or clinic. It's not an individual effort, it's a team effort. So everyone should be engaged. Everyone can have the potential or capacity to influence the project should be included. Okay, so far we learned many tools to develop for quality improvement project. Now is the time to see what would be our methodology. I will discuss 3 methodology in this very limited time. The first methodology is PDSA. PDSA is planning, proposing change idea, and predict what will happen after implementing the idea. So we are proposing change idea and how it will be tested and predict what will happen. This is the phase of planning. In the phase of doing, we will implement change idea. We will collect data, reflect on how well the plan was followed. In the study phase, we will analyze data collected, compare results to predictions. We had predictions here, and then capture learning, learn from implementation of those steps. And in the last step, the act, share final reflections, conclude whether to adopt, or abandon. So PDSA is a 4 steps cycle of activities, of phases of a study. And now we will discuss what are included in the planning phase. In the planning phase, we would describe what you want to accomplish. Aim statement, project charter, describe current process and issues. Current process and issues with that processes. PDSA team members, causes of the problem, fishbone, possible changes or alternatives that might fix the problem, predictions, plan the test of the change. This is important to define what is our intervention, what change we are testing to prove its effectiveness. Smart goals are important. What resources we will need, what action steps, we talked action steps are important. What would be the timeline? And then we will keep in our mind that PDSA cycle is something back to back from the first cycle to the other cycle. So it's not only one cycle of PDSA, it would be something continuously improving our processes in our department. The second phase, now we are here, phase of doing, describing, writing what happens when you run the test, collect data, and use some tools, check sheet, flowchart, streamline map, run chart. These are different tools that we can use in our approach in the doing phase. And we will discuss all of these in the next lecture. Next lecture, totally would go to measurement and tools for measurement and everything that is working with these measures and measurable outcomes in the departments. So document your observation and any problems with that. In the study phase, compare the data you have collected to the data you predicted prior to the change. It's important to have a comparison. Sometimes we compare baseline data with after intervention data. If we don't have any baseline data, we should compare the data with the expected ones, with the predicted ones, with the standard ones. So those are different approaches in quality improvement, and then using some tools to describe the lessons learned from this intervention. And in the act phase, we need to decide about, is this intervention functional? Does it work for our department, for our context or not? So adopt, modify the changes and repeat. Adopt, implement the changes in the small scale, but it needs some corrections. Abandon, change your approach entirely. It didn't work at all. So here you see that the plan didn't work. This is the decision system for act phase, that after watching and supervising this system, we decided to continue this work with some corrections. We decided to continue this intervention without any corrections, or we decided to discontinue this intervention because we watched and we controlled everything and we saw that it's not functional. You see here, everything is a scholarly, data-oriented, and something based on data collection of the measures and comparisons. So statistically, you are deciding to continue or discontinue or revise and refine your intervention in the last phase of quality improvement. This is an example of published article, implementation of disease activity measurement for rheumatoid arthritis patient in an academic rheumatology clinic. And you see the methods is plan, do, study, act. That is the methodology of the publication. And PDSA example, the planning phase, increasing pneumococcal immunization, increasing depression screening for patient, decreasing the amount of physician time, and then having a gap or area for improvement. The doing phase and the studying phase, you see here, they are measuring something measurable, number of patients identified, percentage of a screening completed, number of something, improvement in patient feedback about the screening process. So you see, they are considering some measurements for study phase of the PDSA. Okay, PDSA methodology was discussed in a very brief description. Again, it needs, hours to discuss that phase, step by step and practical, but let me just provide a brief description of all of these methods. The second methodology is FMEA. FMEA is the other methodology. In FMEA, you start from team formation, listing failure modes and effects, ranking severity of those failures, listing potential causes. You remember fishbone? Ranking likelihood of occurrence, listing process controls, ranking detection and detectability. To what extent we are able to detect those failures, calculate risk priority number, take action on high priority risk priority numbers, because we cannot solve all of the issues that we have. So we will have a prioritization method that is risk priority number, and focus and target only the highest priorities and recalculate risk priority numbers. This is a publication, that a project of FMEA in ICU care. We have done it in 2017, and we have published it in a journal. You see here, the methodology is using failure mode and effect analysis. So in the FMEA exam, in the FMEA methodology, we have some templates like this. We should define processes and sub-processes. We should define failure modes in that part of the process. So you see here, this is the first step, assessing patient. And these are the potential failures in that step. In patient assessment, we can have incorrect diagnosis as a failure. What are proximal causes of this failure? You see many here, but just let us check this one. Diagnostic tests are not available in timely manner. So because we don't have timely results of the diagnosis test, we don't have a correct diagnosis, and it leads to some failures in assessing the patient. What are the effects of these failures? What are the effects? And then after filling out this column, we will evaluate the severity of the failure, probability of the failure, likelihood of detection of the failure. Then we will multiply these columns together, and we will have RPN, or risk priority number. And you see everything is objective and measurable here. So RPN is the product of 3 scores that we evaluate within our team. We will discuss together which failure mode is more important and severe, which failure mode is more probable, between 0 to 10. We will score everything. Then, based on RPN, we have high prioritized failures in our department. Then we will develop some actions to reduce the failure mode. You see, that's very rational, very objective, and helpful to discuss within, out of all of issues that we have in ICU, for example, ICU care for central line infections, for example, for intubation related issues or adverse events. What are the most probable failure modes, and how we can act, how we can resolve those issues and problems. So this is the template that works based on FMEA methodology. And that's another, template for FMEA methodology. We call it healthcare FMEA. It has different phases. First of all, steps of the process. Second of all, causes, proximal or distal causes of the problem. Then ranking the risk priority number, severity, detectability, criticality, and then RPN, and then defining some actions to overcome or to reduce the risk of those failures. You see, everything is here documented with this template. Okay, we reviewed 2 methodologies. The first one was PDSA, the 4-step cycle. The second one was FMEA with that RPN risk priorities. And the third one is co-design. I like this method. This method brings service users and health professionals together to improve healthcare experiences, systems, and processes. How? You will invite community. You will invite patients and families who have experiences about the disease. We call that experiences experiential knowledge that patients bring to our tables, to our discussions. For example, who knows chronic diabetes type 2 better than a patient who is experiencing 20 years? Who knows, for example, psoriasis disease better than a patient that suffers from this issue and this medical condition for 10 years? That is called experiential knowledge. Patients who are suffering and struggling with a disease condition are full of information at the level of patients. I do not want to, estimate or overestimate their level of knowledge, but at the level of patients, they are trying to access to a lot of information. They are trying to understand what solution is better, and they are experiencing the results of the medications. They can compare different results. They can compare positive and negative parts of our practices. There are rich resources for judgment and for experiential knowledge to transfer their ideas and experiences to our team to design a better system, to design something that is more functional and beneficial. So incorporating and bringing patients around the table is a part of co-design methodology. You see here, building a team with people who use and deliver healthcare, and frame the problem opportunity, stage 1 of the co-design. Develop co-design preparedness, learn from lived experiences. Please remember these golden terms: learn from lived experiences and gain understanding. There are a lot of opportunities for physician, nursing, and care providers to learn from experiential knowledge of the patients and incorporate those part of information in our fully and purely scientific information that comes from texts or references or different resources for scientific knowledge. So it's very important to include those knowledge in designing a new intervention in our department. Prioritize together. For physicians, something are important, but is it as much as important for the patients and care receivers, for the families? It's important to compromise and come together to prioritize and to make a shared decision-making about quality improvement projects, approaches, and interventions. And then you can check everything. And when you design improvements, test and learn and repeat that and discuss it with care users, they would be a rich source of information for improvement phase of the co-design. Very brief, it has a lot of ideas inside. We need a workshop for co-design. Co-design is a part of systems thinking, and it's a part of industrial systems to design better services for the customers. So it would be very valuable. So far, we discussed 3 methodologies: PDSA, FMEA, and co-design. And this is good for one lecture. It's good to just introduce those methodologies. We review driver map from the previous lecture. That was driver map. We need a driver map to identify what is measurable objectives and aim of the project here. What are key drivers to achieve those goals, and what would be change strategies, change ideas and solutions in this. And this is another, highly professional driver diagram that shows many things. This is aim statement. What's the problem? What's aim statement? Who are team members? Primary drivers that results achieving this aim. What are secondary drivers? what are change ideas and what are priorities for a PDSA project. So from now, I expect to have poster presentations like this. For quality improvement, poster presentations should include the aim statement and problem, drivers and actions and change ideas and timeline, and also measurements. If you remember, we had some measurements in our templates that we'll discuss them in the previous lecture. So this shows, this graph shows many things. It has a lot to talk about quality improvement project, and it would be a type of poster presentation in different conferences that gather best practices of quality improvement around. Measurable outcomes would be discussed in the next lecture, because today we discussed a lot of concepts, and this one would be the last step of our change planning. We need a project plan and activity timeline. A project plan and activity timeline that is time-bound, and every step of the project has a key date. For example, plan meeting first for problem presentation, diabetes visit process charting, fishbone diagram. The other part, submission of templates for each team quality improvement intervention. The other key date, education on how to design a quality improvement study. You see, they are planning, the team plans for key dates and key steps and milestones of the quality improvement project. And again, it's a PDSA methodology that in each phase they are defining and designing different steps, different key dates, different activities and milestones to develop a final data analysis and report the results of the quality improvement project. And that's another example of activity timeline that you see here. Milestones are defined, clarified, and designed in this project planning and activity planning. Okay, that's the, I think, the last part of my presentation. So far, we discussed different steps of quality improvement project planning, from aim statement, project charter, analyzing the issue with fishbone and rich picture. Then we defined driver map. Then we defined methodology that was FMEA or PDSA or co-design. Then we developed a project plan and timeline for everything. And during these steps, we defined the stakeholders who are included and engaged with this project. In my last affiliated university, School of Medicine at UNC, we had different type of resources for everything. You see here, process analysis tools, project charter, driver diagram, project team composition, a stakeholder analysis. There are many resources around for quality improvement project methodologies, tools and toolkits and insights that you need to define a well-developed quality improvement project. And we talked that a well-developed quality improvement project is a project with precise, predefined, measurable objectives and outcomes, and with a time-bound and realistic approach for change. So this is another resource that I can introduce. It's publicly available for all of you. Sorry for missing an opportunity to ask you a question and make an interactive discussion today, because a load of concepts was too much. Thank you for your time and attention. And now you're ready to make a plan change. A plan change always would be more beneficial than disorganized or just writing something comprehensively and writing some reports. So make a plan change and we can't wait to see the results of your efforts. Thank you so much for taking your time listening to this presentation. Is there any question? I am ready to take your question.
Thank you, Marsman, Dr. Marsman.
Have a very nice time.
Thank you.